hey, when it was like this the last time, what worked best, and that may give you some guidance there on how to treat their pain most efficiently. Remember, we need to address that pain promptly. Once we've got pharmacological control on board, we need to look at some other alternatives to pain medications. We can do some relaxation with them, some guided imagery. We can do some breathing exercises. We can darken the room so the patient has an environment in which to experience the pain. If you've ever looked up the rationale for darkening a room, it's out there. Um, but some patients may respond well to that. One of the things that we also need to make sure of when we're addressing pain in this population is find out what an acceptable level of pain is. We typically try to treat pain anytime it's over a 2 in an acute setting. However, this patient population may be quite okay if the pain is 4 or less. So again, you need to do some of that patient-centered care, some of that collaborative care, work with the team, work with the family, work with the patient to decide what an acceptable level of pain is for that patient, because their expectations of pain control may be quite a bit different than what you're used to experiencing. Our outcomes, we would like the patient to be pain-free or at least at a tolerable level, and we need to identify some alternatives for pain control in addition to medications. Risk for infection. Remember, a lot of these therapies are taking out our patient's immune systems, or the disease process itself has impaired our patient's immune response. So we need to look at risk for infection, because that's a major problem with our oncology patients. So we need to assess for infections. Um, Fruits, fresh flowers, seafood, all these things need to be avoided in our immunocompromised oncology patients, patients with bone marrow suppression and what have you. Um, Family members will come in and say, "Oh, this room is just so dark." What they really need in here is some flowers. Well, one of the last things that they need is flowers, so we need to make sure and avoid that. Fresh fruits and vegetables can carry bacteria, virus, whatever. We don't want to expose our patient to that. And again, we want to avoid seafood as well. We need to be ever mindful of their skin integrity. Remember, the skin's main job is to protect them from elements from the outside, from getting to the inside. So we need to assess that skin integrity, especially with our radiation therapies and the such, because once that pathway is open, we have problems. Remember, another big problem with skin integrity and prevention of infection is that nutritional status. If they're not eating, if they're not intaking enough protein, remember, protein provides those albumin stores in the cell that keeps the cells nice and fluffy, as does hydration. So we need to make sure that we're assessing that, because regardless of what we do, if the patient's nutritional status is poor, their chances of skin breakdown go through the roof quite significantly. One of the things that we also need to watch in this group, if they're not able to turn themselves because they're just physically exhausted, we need to make sure that our assistive personnel are actually turning the patient. And if they're not, we need to take care of that, because ultimately it's our responsibility. One of the things that you can do is use a clock, and let your assistive personnel know, hey, every odd hour or every even hour, I expect the patient to be turned, so that if you come in there at noon and the patient's on one side, you come back in there at 2 and the patient's still on that side, you know that there's been a breakdown in that process and that you need to take some action. Looking at outcomes, pretty simple. The patient will remain free of the infection during his hospitalization or her hospitalization. That would be our goal there. Moving on, we're going to look at some diagnostic tests. Some of the tumor markers that we test for, the lab draws, serum lab draws, blood lab draws, can be found on the surface or outside of certain cancer cells. A couple of different screenings are listed there on the screen. Don't waste a lot of time on those. However, one of the ones that you kind of want to look at is that prostate-specific antigen. You want to know that 0 to 4 nanograms per milliliter, pretty much we don't believe them to have any prostate disorder. So 0 to 4 nanograms per milliliter, no prostate disorder. 4 to 19 nanograms per milliliter, 4 to 19 nanograms per milliliter, we may very well have benign prostate hypertrophy at this point. So just that growth that continues to exceed what they actually need there. So they're collecting extra cells in that area. We need to be aware of that. And that, if you'll recall back to 1505, makes urination difficult because of that increase in mass. So 4 to 19 nanograms per milliliters, we're looking at benign prostate hypertrophy. Now there's a little bit of overlap there because in some patients, 10 nanograms per milliliter may be an indicator of prostate cancer rather. So 10 to 120 nanograms per milliliter, we begin looking and comparing other results like that of a digital rectal exam or other study, and look at see if our patient actually has prostate cancer. There's some different types of places that we get material for testing. We can do a sputum culture and look at that. We can do tissue biopsies, and those are fairly definitive. We can do bone marrow biopsies. We can look and find things like anemia, leukemias, multiple myelomas. As you've done this reading, you've also noticed that we can do scrapings and washings, and quite a few different ways that we can actually collect tissue for testing. Tumor classification. One of the areas that we look at to classify a tumor is differentiation. Grade 1, let's back up. Let's look at grade 0. Grade 0 is a cell that looks like a cell that came from the area of origin. So if I take prostate material, I look at it, I see prostate cells. I don't see any change or variation in them. That cell is functioning as it should. And when we go back to microbiology roots, and you remember doing some histology there, so when you look at these cells from a histological perspective, they look like the cells are supposed to look like, and they're functioning like those cells. When a patient has grade 1 differentiation, the cells have started to take on a slightly different appearance. They still somewhat resemble the cell that gave them rise. So if it was a prostate cell to begin with, it still has some of the same characteristics from a histological standpoint as we look at it under microscope. It's also very well differentiated. We can still see, again, what it was, where it came from, and we have a pretty good idea of what that cell is without much work at all. It still retains most of the properties of that cell. Grade 2 differentiation. We're starting to see a little more abnormal cells now. We do see some normal cells, but we're also starting to see more abnormal cells. They're getting a little more difficult to make out as what kind of cell they were originally. When you start getting into grade 3, they're very abnormal. They're poorly differentiated. They don't really look real clearly like the cell that gave them rise. So it may require just a little bit more effort there to determine what kind of a cell it is, especially if it's metastasized to another area of the body. Grade 4, we're looking at that immature, undifferentiated cells. By this point, we've got a fairly advanced cancer, and this patient's chances of survival as a result of that cancer have decreased. So we need to be aware of that. So just if you hear a physician mention grade 1 through grade 4, this is some idea of what they're talking about. Remember, the lower the grade 1s chances of survival are much better than a patient with grade 4 differentiation.